So we learned a little bit about cartilage back when we talked about bones and the ossification process, but we also want to be aware that cartilage is a type of connective tissue. So technically it should have been talked about also back when we talked about connective tissue. And what it does is it provides a support or a framework for which other things can move, build on, or move. The matrix of cartilage, again, no surprise, cartilaginous or collagenous fibers in a gel-like ground substance. So that tells us that cartilage isn't quite as rigid as bone, although it is fairly structural. And that gel-like ground substance is a protein polysaccharide known as glycosaminoglycans. And we won't talk any more about that, but cartilage cells are chondrocytes. Remember from a previous crash course video where these chondrocytes started as chondroblasts, which laid down cartilage, and then become chondrocytes when they're mature and maintain the cartilage. And they're in small chambers called lacunae. So here would be a lacuna, here would be a chondrocyte, and here would be another chondrocyte within the lacuna. They lack a direct blood supply, so they do not heal easily or quickly for that matter. And they are typically covered with a thin layer of connective tissue known as the perichondrium, kind of like the periosteum of bones. And it's the perichondrium that contains an adequate blood supply because that's where dividing cells are going to be that help to maintain and build more cartilage as it's needed. 3 types of cartilage that you should know: hyaline cartilage, elastic cartilage, and fibrocartilage. We'll talk about in the next couple slides. Hyaline cartilage is the most common type of cartilage you'll find in the body, and its primary function is one, it serves as the embryonic model for the skeleton, as we learned with endochondral ossification, and it also provides support when we talk about joints. It provides some protection also when we talk about joints, and it provides a framework when we talk about the ossification process, as well as major structures in your body like the trachea or bronchi or even the nose. Second type of cartilage is elastic cartilage, and by its name you can tell that it contains many elastic fibers, so more elastin than collagen. And when you stretch it, it resumes its normal shape, which is the definition of elasticity. Function: to support, protect, and provide a flexible framework. So you'll find cartilage in your outer ear. Notice that if you bend your ear, it's flexible. It provides a framework. And part of your larynx. And it is more, obviously, being elastic, is more flexible than hyaline cartilage. And the third type is fibrocartilage. And fibrocartilage is the toughest type of cartilage. It's very dense and it's very strong. And so you would see that very much in supportive roles in the body and as a shock absorber during body movement. So key places for those to be are places where a lot of weight is borne. So the vertebrae, which holds the weight of the entire trunk, the knee, which holds the weight of most of the body above the knee, and the pelvic girdle, which is involved in a lot of movement, so it has to be able to absorb shock. All right, so all that middle stuff that I skipped over was covered in sufficient detail in your crash course. So what wasn't covered are joint disorders, and the only one we're really going to cover is rheumatoid arthritis. And rheumatoid arthritis, at this point, we consider it to be an autoimmune disease, meaning that your own immune system attacks parts of the joint and leads to its destruction through an inflammatory process. The incidence is higher in women than men, and the reason for that is autoimmune disorders tend to be higher in women than men. But it can affect all age groups, so not just not just the elderly are affected, but even children can be affected as well. So with rheumatoid arthritis, you have inflammation of the joint, and since the joints are synovial joints that are affected, we call it synovitis. marked joint inflammation and cell proliferation. So the joints get inflamed, a lot of cells get produced during that period, and the pathology goes through extensive remissions and exacerbations of this inflammation process. Again, it's an autoimmune response, and in rheumatoid arthritis patients, we find that there are antibodies against IgG, so antibodies against antibodies. And how that exactly relates to the destruction of the joint is currently unknown. Through the process of inflammation, we have pannus formation, which is like a granulation tissue that kind of spreads throughout the joint and leads to the release of certain enzymes. Those enzymes will cause the cartilage to start to erode, and because cartilage provides structural support to the joint becomes unstable. As this process goes on, you have the exacerbations and the remissions. Some of that tissue heals by secondary intention, heals by scar, and so we have a lot of fibrosis going on, a lot of connective tissue, collagen being laid down that ends up calcifying and taking up the joint space and making the joint very rigid. And that rigidity of the joint is called ankylosis. The joint's fixed in place and it becomes deformed if left untreated. Because the joints don't move anymore, the muscles aren't going to be working as frequently, so the muscles that control the joints are going to atrophy. Bone alignments are going to shift, leading to, because of the rigidity, the ankylosis of the joint, so leading to more deformation. Because of the inflammation, you're going to have muscle spasms. It's going to irritate the muscle. The muscles are going to involuntarily contract, and those are going to hurt and lead to further contractures and deformities in the rheumatoid joint. So if you look at the pictures down here, you notice the inflammation in the metacarpal to phalange joints and the deformation of the joint, pushing the phalanges in a medial position. Remember, anatomical position, if the hands are in this position, those are not anatomical. Palms should be facing forward, so those contractures would be facing medially, not laterally. If you remember back a few slides, although we've mostly talked about the effects of joints, rheumatoid arthritis is a systemic inflammatory disease, and because of that inflammation, that systemic inflammation, we're going to have fatigue, depression, general feeling of blah, not feeling well, not wanting to eat, low-grade fevers related to the inflammatory process, and an iron deficiency anemia due to the sequestering of iron in the fever process. The inflammatory process may also lead to nodules being formed on the pleura of the lungs. Remember, those are the membranes that slide past one another when the lungs are expanding and contracting, and that would lead to difficulty breathing and maybe some chest pain. You get nodules on heart valves, which could lead to all kinds of cardiovascular problems, and nodules on the eyes, which lead to vision or eye movement disorders. So the way this is treated typically is a balance between rest and moderate activity. You want them to rest because this disease process is very taxing, so they need to rest to maintain their energy. But you don't want them to rest too much. They need to get up and move around so those joints can remain mobile as well. So it's a delicate balance between the two. Heat and cold applications: heat to get blood to those joints so they can remain healthy. Cold to reduce some of the inflammation if it gets too painful. Of course, physical and occupational therapy: get these patients up, get them moving around. Non-steroidal anti-inflammatories. But if there is severe inflammation, they'll tend to use glucocorticoids. The problem with that is glucocorticoids are an immune suppressant, which will help with the inflammation and help with the autoimmune disorder, but it could leave you open to infections because of the effects on the general immune system. Of course, they're going to be in pain, so you want to give analgesics, and in severe cases or more resistant cases, immunosuppressants. Again, knocking down that immune system so that you don't have this autoimmune response and continued inflammation. But again, the problem with that is susceptibility to infections. And also, there are biological response modifying agents, and their job is to reduce specific inflammatory or immune agents. So there are some specific agents that are known to be involved in the process of rheumatoid arthritis, the inflammatory process, and so there are certain agents that will attack just those molecules to help reduce the exacerbations. Now, you're probably going to get much more about this and much more detail about this in your clinical medicine classes, but this is just kind of a primer to what kind of disease processes can occur in synovial joints.